Hello, my name is Dr. Ann So, and I'm a professor in the Department of Thoracic Head and Neck Medical Oncology at MD Anderson Cancer Center, and I am the director of the Mesothelioma Program and director of the Thoracic Chemoradiation Program. Today, we compare two patient cases that relate to the use of frontline immunotherapy in metastatic non-small cell lung cancer. These two cases have similarities, and yet the recommended treatments may be different. Let's take a look at the cases. For patient case 1 is a 64-year-old clinically asymptomatic woman with metastatic non-small cell lung cancer adenocarcinoma involving bilateral pulmonary metastases, a left adrenal nodule, and multiple bone metastases. Her molecular profile shows that she is KRAS mutation positive but wild type for all other genetic aberrations, and her tumor mutation burden is 6 by Foundation 1 next generation sequencing. Her PD-L1 immunohistochemistry status is 30%. For patient case 2, this is a 68-year-old clinically asymptomatic woman with metastatic non-small cell lung cancer, also adenocarcinoma, involving bilateral pulmonary metastases, a left adrenal nodule, and multiple bone metastases. Her molecular profile shows that she's KRAS mutation positive but wild type for all other genetic aberrations, and her tumor mutation burden is 3 by Foundation 1 next generation sequencing. Her PD-L1 immunohistochemistry status is 60%. So as you can see, both cases are very similar, but there is a difference. So the question is whether this difference leads us to a different therapy or not. For a little bit of background, the standard diagnostic practice for patients with newly diagnosed metastatic non-small cell lung cancer is to perform molecular profiling. This includes both genetics and also immunohistochemistry. The 2017 ACP IASLC AMP update recommends that newly diagnosed non-small cell lung cancer adenocarcinoma patients and certain squamous cell carcinoma patients, if they're a never smoker, have mixed histology, or small biopsy specimens, must receive biomarker testing for EGFR ALK ROS1, and they should be considered for testing for BRAF, MET, RET, ERB2, which is also HER2, and KRAS. PD-L1 immunohistochemistry should also be tested, regardless of histology, for all frontline metastatic non-small cell lung cancer patients. Prior to the era of immunotherapy, patients with metastatic non-small cell lung cancer with no oncogenic driver mutations would receive a platinum doublet or a platinum doublet plus bevacizumab if they were non-squamous and bevacizumab eligible. The KEYNOTE-024 trial identified a population of patients that had a greater benefit from frontline immunotherapy rather than a platinum chemotherapy doublet. Subsequent combination chemoimmunotherapy studies such as KEYNOTE-189 and IMpower 150 have also shown survival benefits for frontline non-squamous non-small cell lung cancer patients. So both of these cases have identical clinical presentations. However, their molecular profile is different. The Phase 3 KEYNOTE-024 study showed that newly diagnosed non-small cell lung cancer patients with a PD-L1 immunohistochemistry greater than equal to 50% and no actionable EGFR ALK alterations had a significant improvement in PFS and OS with single-agent pembrolizumab compared to a platinum-based chemotherapy. The median PFS was 10.3 months with pembrolizumab versus 6 months with chemotherapy, for a hazard ratio of 0.5 and a p-value that was statistically significant. The median overall survival was also significantly prolonged, although the median was not reached in either arm at the time of the analysis. The hazard ratio was 0.6 and the p-value 0.005. Pembrolizumab also increased the overall response rate to 44.8% compared to 27.8% with chemotherapy. The FDA therefore approved frontline pembrolizumab for patients with metastatic non-small cell lung cancer who are PD-L1 immunohistochemistry positive greater than equal to 50% in October of 2016. For patients who do not have a PD-L1 immunohistochemistry greater than equal to 50%, there are two combination immunotherapy chemotherapy options. The KEYNOTE-189 trial randomized 616 chemo-naive patients with metastatic non-squamous non-small cell lung cancer and no actionable EGFR ALK mutations to receive platinum pemetrexed pembrolizumab versus platinum pemetrexed placebo for 4 cycles, followed by maintenance pemetrexed with or without pembrolizumab for up to 35 cycles. The triplet immunotherapy regimen improved the median overall survival for a hazard ratio of 0.59 and a p-value less than 0.001. The median PFS hazard ratio was 0.52 and a p-value less than 0.001, favoring the triplet immunotherapy regimen. Furthermore, the overall response rate was higher at 47.6% with the pembrolizumab chemotherapy arm versus 18.9% in the placebo chemo arm. In the subgroup analysis, patients who had PD-L1 less than 1% had a hazard ratio of 0.59, and for those whose PD-L1 immunohistochemistry was between 1 to 49%, the hazard ratio was 0.55, favoring the triplet regimen. It is therefore now standard of care to consider carboplatin pemetrexed pembrolizumab in patients with PD-L1 immunohistochemistry less than 50%. In December of 2018, the FDA also approved an additional frontline chemoimmunotherapy regimen for non-squamous non-small cell lung cancer patients, the IMpower 150 regimen, which is a quadruplet regimen of carboplatin paclitaxel, bevacizumab, and atezolizumab. The median overall survival with the addition of atezolizumab was 19.2 months compared to 14.7 months in patients who received carboplatin paclitaxel bevacizumab. The hazard ratio 0.78 and the p-value was equal to 0.016. Moreover, the 2-year overall survival rate with atezolizumab was 43% compared to 34% with a triplet of carboplatin paclitaxel bevacizumab. The quadruplet regimen improved median progression-free survival by 1.5 months compared to carbopaclitaxel bevacizumab for a hazard ratio of 0.71 and a p-value highly statistically significant. So bring it back to our 2 cases. The difference between our 2 frontline cases is that the PD-L1 immunohistochemistry expression was the deciding factor for initial therapy. For case number 1, the patient had a PD-L1 immunohistochemistry expression of 30%, which leads us to the treatment options of chemoimmunotherapy combinations. Either carboplatin pemetrexed pembrolizumab or carbopaclitaxel bevacizumab atezolizumab can be used. Whereas in case 2, the PD-L1 immunohistochemistry expression was 60%, and therefore the best treatment option in an asymptomatic patient was pembrolizumab alone. I'd like to thank you for listening to this week's episode of the ASCO e-Learning Weekly Podcast. For more information on the treatment of non-small cell lung cancer patients, including additional patient cases and opportunities for self-evaluation, please visit the Comprehensive e-Learning Center at elearning.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.